Now this question is very important. So where are we now? Now we are looking at the etiopathogenesis of carcinoma cervix, and what are the tests which are employed for the diagnosis of carcinoma cervix, what is the staging of carcinoma cervix, and discuss the management of stage 1 of carcinoma cervix. Now we'll be discussing the management of CS cervix in detail in this video. Okay, management in detail, very important. And in the last 2 years I had seen questions coming in this screening process, and very importantly the vaccination part. Why? Now you'll understand the reason, because recently in the interim budget, Nirmala Sitharaman ji has announced that we are going to educate all the Indian women in the reproductive age group to go for vaccination. Okay, we now have a cheaper version of the vaccination, and we are trying to implement or include it into the vaccination schedule for reproductive age group. I think next year you might expect a question on the vaccine as a repeat, or anything related to carcinoma of cervix, maybe in the pathology as the histopathology of carcinoma of cervix, or maybe the screening part, that is what is pap smear, or the management part. Anything can be important for the next year, okay, because it's announced in the budget and it's in the current discussion. Like in the medical era, we are discussing about this condition. Now, etiopathogenesis. Many of the students are only writing etiology. It also includes pathogenesis. That means when I say pathogenesis of CS cervix, HPV, the role of E6 and E7 is very important. That includes RB gene and P53, right? So, if you do not include these 3 points in the answer, you will not get marks. Okay? This answer is incomplete without these 3 important points. If you're parallelly preparing for NEET PG, I think E6 and E7 importance you do know, right? There will be a lot of questions in this segment. Now, CS cervix, apart from human papillomavirus infection, STDs, early coitus, multiple sex partners, all this multiparity, all this increases the chance of contracting HPV, poor personal hygiene, poor socioeconomic status. Smoking reduces the local defenses. Immunosuppression also reduces the local defenses. Women who are on OC pills and progesterone therapy for long time are also predisposed for cervical cancer, as I told you. And in utero exposure of diethylstilbestrol lead to adenocarcinoma of the cervix. So these are all the etiology or risk factor. So when I say the exact cause, it's identified that HPV is central to the development of cervical neoplasia. So all these factors, except this OC pills and utero, everything they revolve around HPV. Now in the HPV, there are high risk variants and low risk variants. Okay, HPV 16 and 18 are the most common ones, high risk variants, which leads to cervical carcinoma. There are others also, like 31 to 68. There are multiple. Just go through them. What is the topic of interest is when you have these things, that is HPV high risk variants. For example, HPV enters into the host cell. Let's take it like this. So this is the host cell, and this is the nucleus of the host cell, and this is the HPV. Okay, HPV is entering into the host cell now. Okay, after entering into the host cell, HPV is a virus. So the baby particles of the virus are virions. So for this production of the virions, HPV uses the DNA polymerases of the host cell. But whenever the virions form, these are the smaller virions from the bigger virion, they should come out of the squamous cell. They should shed from the surface of the squamous mucosa. Okay, so that the replication continues. But in a normal squamous mucosa, normal cells, in a normal woman, the shed is not allowed. But HPV solves this problem through or by production of 2 viral oncoproteins, that is E6 and E7. So the shedding of the virions from the squamous mucosa is done with the help of 2 viral oncoproteins, that is E6 and E7. And this E6 and E7, because it is produced by these things, okay, these variants, that's why these risk subtypes are known as high risk variants. They are not low risk, they are high risk. So in any high risk HPV variant, they produce E6 and E7, and E6 inhibits P53 tumor suppressor, E7 inhibits RB gene tumor suppressor. That's it. If you know this much, it's more than enough. So how it is done, at what steps, whether it is ubiquitination or degradation, and what genes it is targeting, all this depth is not important for exam point of view. In US summary, they ask questions from this segment, but not for UPSC CM, okay, civil service. So this much if you know, it's well and good. So this will conclude etiopathogenesis part. The staging, I had seen many of the students giving older staging system. In 2018 they have modified it, but none of the students are writing this, as I could see. So we have updated this even in our latest edition to notes, that FIGO 2018 guidelines are the ones which we are following. Okay, now there are two ways of looking at it. If you look at the staging of gastrointestinal cancers, we have kind of staging called TNM staging. Tumors are kind of staged separately, nodes are staged separately, and metastasis is staged separately, right? But now CS cervix has a peculiarity, because even the nodal involvement is also included in the FIGO staging as a separate entity, as you could see here. 3C1, 3C2 and 4B includes superficial inguinal lymph node involvement. So lymph nodes are integral part of the staging system. So that's why we got, if someone asks you what are the stages of, or how do you stage carcinoma cervix, we stage it by 4 stages: stage 1, 2, 3 and 4. So basically when you look at this image, stage 1 means, so this is the uterine body and this is the cervix part in the orange color and uterus in the pink color. Any invasive carcinoma which is restricted or confined to the cervix, that is stage 1. Confined to the cervix, as you can see here, it's within the cervix. So when it is confined to the cervix, it's stage 1. When it is not confined to the cervix but spreading beyond the cervix, it doesn't mean that any involvement of the uterus is not staged. It can even go up like this, right? So involvement of the uterus, we are least bothered. If any cervical cancer which is confined to the cervix is now spreading into the uterus, still it is stage 1 only. But if it is spreading to the upper 2/3 of the vagina, if it is spreading to the upper 2/3 of the vagina, or if it is slightly spreading to the parametrial region, then we call it as stage 2. So what is parametrium? You know, right? We have a uterus like this, okay, uterus, and you have a cervix like this and vagina. Now this area is parametrium. Okay, this is passage of the ureter. So this area surrounding the uterus, which contains all the ligament supports of the uterus, is the parametrial region. If the tumor is spreading into the upper 2/3 of the vagina or into the parametrium, then we are calling it as a stage 2. Substaging will slowly get into the details, but now try to understand what is stage 1 and stage 2. Stage 3 means tumor spreading to the lower 1/3 of the vagina, not upper 2/3, it is lower 1/3 of the vagina, or tumor obstructing the ureter leading to the impairment of the kidney function, that is hydronephrosis or non-functioning kidney, because uterus is in the parametrium. Whenever parametrium gets infiltrated, it leads to loss of kidney function also by hydronephrosis. Or if the tumor is spreading to the pelvic wall, so the adjoining pelvic wall, then we call it as stage 3. So invasion of lower 1/3 of the vagina or hydronephrosis or non-functioning kidney, pelvic wall involvement, and even pelvic para-aortic nodes are located in this region of the parametrium, right? So involvement of the pelvic and para-aortic nodes, they are also part of stage 3. Now stage 4 is extension beyond the true pelvis. That means if it is involving the adjacent organs like bladder or rectum, okay, or any distance organ, when we call it as a stage 4. The same thing, let's go to the subdivision. Now you're looking at a case of stage 1A. Why this substaging is also important? Because in the exam, in UPSC itself, they might ask you, how do you manage a case of stage 1A? Or how do you manage a case of stage 3C1 or something like that? So they're asking you specifically, even in MCQ based exams like NEET PG or USMLE step 2, they're asking you by mentioning the stage as an entity. How will you manage this? So based on, you need to know the details of staging in detail. Now 1A, so as I told you, stage 1 is confined to the cervix. Within that you have 1A and 1B. 1A means micro-invasive carcinoma. That means you cannot see it with a naked eye. That means the size is less than 5 mm. Size is very low. Within that, If the size is less than 3 mm, we call it as stage 1A. If the size is less than 5 mm, that is 3 to 5 mm, we call it as 1A2. So this is 1A1 and 1A2. Now clinically visible lesions are 1B. Clinically visible, these are microscopic. Clinically visible means it starts from 5 mm, it goes up to more than 4 centimeters, any of size. But 5 mm to 2 centimeters is 1B1, 2 centimeters to 4 centimeters is 1B2, and more than 4 centimeters is 1B3. Just make a note of this. Any tumor more than 4 centimeter maximum diameter, any tumor, any cervical tumor with a size more than 4 centimeters, you cannot surgically resect it. The only available option is chemoradiation. So that's why this stage 1B3 is recently coined, and it is very important. If it is more than 4 centimeters maximum diameter, you cannot cure it surgically. So this point, please make a note. Now let's get into the stage 2. Stage 1A is done. Okay, stage 1 is done. 1 is divided into 1A, 1B based on the size. 1A is again divided into 1A1 and A2. 1B is again divided into 3. B1, B2 and B3. These are microinvasive starting from a size of, what is that size? The starting size is, here you have less than 3, less than 5, 5 to 2 centimeters, 2 to 4 centimeters, and more than 4 centimeters. So it's all deals with the centimeters. Just try to memorize them. Now stage 2, as I told you, is either involvement of the upper 2/3 of the vagina or parametrial invasion. Okay, so if it is not involving parametrium, it is 2A. If it is involving parametrium, it is 2B. Okay, not involving parametrium means it is involving the upper 2/3 of the vagina, right? So this is 2A is again on the basis of the sizes, whether it is less than 4 centimeters or more than 4 centimeters. When I say this more than 4 centimeters, that is 2A2. Do you remember this dictum? Any tumor with more than 4 centimeters in dimension is not surgically resectable. You cannot resect it surgically. That is 2A2. Now, stage 2B means parametrial invasion. So tumor involves lower third of the vagina with no extension to the pelvic wall, or yes, extent to the pelvic wall or hydronephrosis or non-functioning kidney is stage 3B. Now 3C, as I told you, in stage 3 we have pelvic and para-aortic lymph node involvement. 3C1 is pelvic lymph node involvement. 3C2 is para-aortic lymph node involvement. I'm taking more time in explaining this thing. The reason being, if you don't understand staging, you will not understand the management per se. Now stage 4A and 4B are simple metastasis. Spread to rectum and bladder is stage 4A. Any distance organ is stage 4B. Now it can go to lung, it can go to bone. Most commonly involved organs. Even brain mets can be seen. Okay, even the liver mets. Now superficial inguinal lymph node is staged as stage 4B. It's not included in the regular pelvic and parietic lymph nodes. Superficial lymph node involvement is stage 4B. Now we're done with the staging part. Now how will you manage? As per the question, it is stage 1 management. Stage 1, as you know, includes till 1B3, right? Now we'll first discuss the stage 1, then we'll get to the other details. Now when you see any case of CS cervix, the management depends whether, okay, it's very important. Management depends on two things. One thing, the stage, okay, and very importantly, what is that? Lymphovascular invasion. Okay, if there is any lymphovascular invasion, and very importantly the age, that means young or old. So the treatment varies depending upon which stage it is. Lymphovascular invasion is seen or not, whether the woman is young or old. In any old woman, we go for kind of radical hysterectomies, but in any young woman, we go for a conservative approach, that is vaginal trachelectomy. Vaginal trachelectomy or radical hysterectomy. You don't have to remember everything, just remember the basics, then it becomes easy for you. What I'm trying to tell is, if you see any case of CS cervix in a young woman where surgical resection is possible, Next, I'll tell you in which stage surgical resection is possible. But for now, what I want you to remember is, or memorize is, in any woman in a surgically resectable young woman of CS cervix, we go for vaginal trachelectomy. Okay, we go for vaginal trachelectomy. But in old women, we go for radical hysterectomy. Okay, this is the two things that I want you to remember. Now, surgical resection is not possible in three things. That is stage 1B. As I told you, size is more than 4 centimeters, bulky tumor, surgical resection is not possible. Similarly, stage 2A, size is more than or equal to 4 centimeters, bulky tumor, surgical resection is not possible. Even stage 2B also, okay, stage 2B onwards, okay, we do surgery only till stage 2A. So all these things which I just discussed, stage 1A, 1A2, 1B, 1B1, 1B2 and 2A1, we can do surgical resection. Beyond 2A1, that means starting from 2A2, surgical resection is not possible. We only go for chemoradiation. So if you see a female with stage A2 or female with stage 3 or female with stage 4, we only go for chemoradiation. That too, in female with stage 4, we don't even do chemoradiation. We only do palliative care. So what is chemoradiation? Chemoradiation means actually it is a radiation therapy, but we are giving chemotherapeutic agents like 5-fluorouracil and cisplatin. They act like radiosensitizers. They increase the efficiency of the radiotherapy. So the radiotherapy techniques are, it can be brachytherapy or it can be external beam radiotherapy. I'm not getting into the details of this, but these are the things we do. In chemoradiation, chemoradiation is good, okay, it gives good results. But in earlier stages like stage 1, stage 2A till stage 2A2, till stage 2A1, instead of going for chemoradiation, we are going for surgical treatment for few reasons. That means chemoradiation has side effects like ovarian failure, vaginal fibrosis. So that's why, to avoid this problem of premature menopause and also impairment of the coital function in any young woman or in any old woman with early stages, it's better to go for surgery to avoid these complications of premature menopause and coital impairment, coital impairment, because they are all psychological problems, right? So that's the reason. Otherwise, chemoradiation is a good option. Now, what surgical options do we have? When you see a case of 1A1 in the early stages without any lymphovascular invasion, conization is the best technique to go. That too in a young woman. Conization with a clear margin is well and good. But if you see elderly and paras women, better to go for hysterectomy for complete cure. But in 1A2, there will be definitely lymph node involvement. That means if there is a lymph node involvement in young age group, go for vaginal trachelectomy. This vaginal trachelectomy or Darjan's vaginal trachelectomy followed by cervical circlage is advised. Then we go for laparoscopic lymphadenectomy, because lymph node involvement is a dictum here in 1A2 onwards. So from stage 1A2 onwards, if you are doing any surgery, we go for lymphadenectomy. Even in stage A1 also, we go for pelvic lymphadenectomy or sampling, because if there is a suspicion of lymphovascular involvement. That means that's it. In stage 1B, 1B1 or 1B2 or 2A1, we go for some extended surgeries like Warthin's hysterectomy or type 2 hysterectomy. It's a extended surgery. Multiple things are removed. Warthin's or radical hysterectomy or extended hysterectomy or type 2 hysterectomy. There is another operation which are obsolete now. Shorter's extended vaginal hysterectomy or Taussig's laparoscopic lymphadenectomy. We don't do all these things. But even after doing hysterectomy, we give some primary radiotherapy in these cases if there is a lymph node positivity. If you see any lymph node positivity after the surgery, we have to go for pelvic irradiation to prevent the occurrence of the relapse. So this is how you manage a case of CS cervix. Now, I always tell you, okay, staging is good. But how do you stage? For staging, you have to go a lot of investigations, right? So previously, the staging is only based on clinical stuff, but now we are doing a lot of investigations for staging. So screening is pap smear. Pap smear is supported by all these testings. But I'm not talking about screening for CS cervix. I'm treating a already diagnosed CS cervix. So we go for colposcopic biopsy to look at the histology, to look at the grading. Okay, colposcopic biopsy, and to look for the depth. Okay, and for sizing of the tumor and all, for we have multiple options, like you can go for cystoscopic and proctoscopy to look for involvement of the bladder or rectum. You can go for MRI, which also tells you perimetral invasion. You can go for CT, which tells you about lymph node involvement or any bone mets, can be easily identified by CT. We also do some basic metastatic workup like chest x-ray. Chest x-ray is also done to look for the surgical fitness, right? To rule out any obstructive diseases, COPD, if there is a history of smoking. PET CT is gold standard for looking for metastasis. Okay, and basic lab tests are done as a surgical profile, because you're subjecting this patient to surgery. For any surgical answer, you have to write surgical profile. Okay, even IVP is done, you know, right? There is a problem of hydronephrosis, non-functioning kidney in this case because of perimetral invasion leading to the kinking of the ureter, right? So you have to do IVP in these cases. So these are all the investigations we do. The same thing is given in a here in this we gave it in a algorithmic fashion. That is, where you do screening. If there is CAN1, we don't treat. If CAN2 or 3 is done, cervical intraepithelial neoplasia is discussed as a separate entity in pathology. I'm not discussing it here. Okay, if it is a diagnosed case of cancer, then we go for CT, PET, cystoscopy, proctoscopy, IVP, chest X-ray. Then we go for the treatment. The treatment, as I already told you, is given as a flowchart manner here. So this will conclude the discussion on the management of carcinoma cervix.